Okay. Well, I think we'll go ahead and get started. Thank you, everybody, for joining us today. We know that it is a quick change in plans, and so um, we made the call yesterday to rain check it, and then I spent the rest of the evening trying to put a PowerPoint together uh, for us to share space today. And I wasn't sure who would be here and who would be sharing in this space. And so we are brought here together in remembrance and to celebrate the anniversary and the life and the legacy of Amber Isaac Rose, who died last year of preventable pregnancy related causes at Montefiore Hospital in the Bronx. Um, and so I didn't and don't want to put anybody on the spot who wasn't necessarily planning on sharing, but I also didn't want to dive into a PowerPoint presentation about policies. If there are folks in this space who knew Amber and who wanted to share a little bit about her, um, and yeah, and had anything to share with folks who are gathered here about her life or any remembrances. So this is an invitation. If you did know her and if you wanted to share, I just wanted to give space for you and for us to hear and learn more about her. Okay. Well, we so I don't know. I don't see anyone in this or uh well thank you all for gathering. Um and I think we are hopefully many of you are already have some familiarity with Amber's story and the events that transpired and that led up to her death. And if you're not super familiar with the details, I'll probably have you refer you to other things that are available and in the public that share that story. Um, so that today we have time to talk more and really focus on solutions and what we can be doing to prevent um, future preventable maternal deaths and to honor Amber's legacy and try to find some accountability in the wake of what happened. Um, my name is Katie Season. I use she, her pronouns, and I am a reproductive justice activist and a birth worker organizer. And I'm also a nurse whistleblower. And I'm essentially like the volunteer policy person for the Save a Rose Foundation, um, or one a volunteer policy person for the Save a Rose Foundation. So I got involved in the Black maternal health activist space after the death of two Black women in a 4 month span at the state run hospital where I was working in central Brooklyn in 2017. Um, and that really started me on a journey to try and find some accountability for what happened in the hospital leading up to those deaths. And so after Amber tragically died last year, I was able to link up with Bruce. And we have been dreaming together about potential policies, both to prevent future events like this and to provide support to folks who have experienced these losses. And so I'm super glad that you guys are all here today to learn more about those solutions, because really the main solution is us working together to figure out what solutions are going to be and implement them. Um, I'll refer to a form several times throughout this. Um, throughout the presentation. And I just dropped the link to that in the chat. Um, so if the Movement to Birth Liberation database doesn't already ring a bell for you, and you don't know whether or not you're already in there, please go ahead and fill out the form to join Save a Rose grassroots policy team, because us working together over time is what's going to make all of the things that we're about to talk about possible. Um, so, and then I this I'm recording this to go on YouTube. So if you have any questions or comments, but you don't feel comfortable unmuting yourself, please put them in the chat. And then if somebody can keep an eye on the chat for me, and if somebody is asking questions there, please unmute me. I have a hard time, like, just assume if something's in the chat, I can't see it. Or that I haven't seen it, because I get it's a lot to pay attention to. So please feel free anytime you have any questions, concerns, how does these two things connect? Please feel free to unmute me and let's have this be a conversation. So and I guess I'll just pause here again if there was anyone from the Save a Rose team that wanted to say hi that I missed. Okay, cool. So I wanted to, I'm gonna, also, how much time, how do we have today? Who knows? It's a rain check event for something I'm sure we were all planning at being at for a couple of hours. I'm gonna try and get all the important information in the first hour, and then I'm free to hang out for another half hour, hour or so if people have questions or want to get into anything. But I wanted to start with the things that are most time sensitive and the policies that are out there that we could get passed this year that would have a really transformative impact on the maternal health landscape in New York, and that will kind of pave the way towards accountability in Amber's case. And so the first policy I want to talk with you guys about is the New York Health Act, which is a state level Medicare for All bill that would start a system of universal guaranteed health insurance in New York that would cover every New Yorker, regardless of age, immigration status. If you are a resident of New York, like if you have a piece of mail in your name with a New York address, you can get health insurance in New York that is paid through taxes. 90% of New Yorkers will pay less in their taxes towards healthcare than they are currently paying now in healthcare. And that whole 10% of people who will be paying more are all very rich and healthy folks who can afford to be paying more into the system. So while single payer healthcare is probably not a politically viable policy on the federal level, in New York, we have the support that this legislation needs to pass. Both the state Senate and Assembly tomorrow, if the speakers of the state Assembly and Senate woke up and decided they wanted to call this for a vote, we would pass this, and it has a 2-year implementation phase, and 2 years later every person in the state of New York would have health insurance. So I wanted to, if you're familiar with Amber's story, you may be thinking, how do these two things connect? Because Amber actually had really good health, or had good health insurance, or what's considered good health insurance, at least in our system. And so I want to point out there's a bunch of different ways that these things intersect, and I want to kind of lay them out for us today. And so the first point, and this is less for Amber's case specifically, but holds true for many people who are in a similar position to Amber, who a college educated Black woman living in New York City. And so the first reason why this is important is because even if even if you have good insurance, if a lot of other people who receive health care at the same institution where you're receiving health care do not have good insurance, then that affects the institution's overall ability to provide care. And so even if individual providers have strong insurance based biases and provide like better care to people on better insurance and worse care to people on worse insurance, I don't necessarily think that's the case in practice. And B, even if that were true, the people on better insurance would still get worse care because all of the services that impact everybody in the hospital. So, say the laboratories, the laboratory's ability to process labs quickly and to quickly, accurately, and to report any concerning values to healthcare providers in a way that makes sure it gets on their radar. Um, if you go to a hospital where even if you have good health insurance, if everybody else has bad health insurance, and what makes that health insurance bad is that they don't reimburse at a high rate. So the money they are paying your provider to give you care is much less than the true cost of that care. Well, then, for instance, the laboratory serving that hospital doesn't have the resources to operate in, to the best standard possible. And so everybody receiving care at that hospital gets worse care because the laboratory services are worse because the overall income to the hospital is less. And that holds true for any service that affects the overall hospital, like imaging, like transport, um, like certain subspecialties in medicine. And those are all particularly important in managing obstetric emergencies. And we know that many maternal deaths in New York City are essentially severe maternal morbidity gone wrong, or near misses where we don't where we where it's not a near miss anymore. So there's an emergency that is not being handled properly. Many of us have seen emergencies handled properly and those people are doing fine now. Well, it's only a several minute difference between handling it properly and handling it improperly and losing that patient. And if the overall services in a hospital have been defunded because many other people who receive care where you receive care, their insurance isn't paying a fair amount into the institution, that diminishes overall quality. So what we see in Brooklyn is this is a map of the 10 hospitals in Brooklyn that have maternity services ranked from safest to most dangerous. And you can see that the three most dangerous hospitals in Brooklyn are all right in the middle of segregated Black Brooklyn. And that and that overlaps a lot with the percentage of Medicaid patients that these hospitals serves. So um, if you like if you underfund a hospital, if you have if you have these private hospitals that see I think NYU Langone sees 7% patients on Medicaid, and Kings County and downstate see 97% of their patients who are on Medicaid. So you have hospitals that are taking in half as much money as other hospitals. So obviously, the quality of care that that hospital offers to every patient who walks through that door is different, regardless of whether that patient has a college education or is on good insurance. There are a lot of college educated Black women who live in these neighborhoods who, if they call an ambulance, they're going to get taken to one of these hospitals just by merits of what's geographically closest in a course of an emergency. And then when an ambulance takes them there, there's not the staff there necessary to provide emergency care, and we have unnecessary deaths. So that's one reason, is because even if you have good insurance, just the fact that we have a system of good and bad insurances is bad for everybody. Um, and that kind of takes us to our next point, because the map of the Bronx, of hospitals in the Bronx, shows a very different pattern than what we see in Brooklyn. And that is mainly that the two most dangerous hospitals in the Bronx are both, well, the two most dangerous hospitals in Brooklyn are both publicly run, and have been, there's news article after news article going back decades about how these hospitals have been underfunded and how the budgets have been cut beyond what staff and union leaders say is reasonable and what is able to be absorbed, while still providing safe patient care. On the other hand, Montefiore is a private hospital and one of the 5 private networks that netted $1 billion of net revenue in 2016. Now, I do quotes around net revenue because the private hospitals are considered nonprofits. So it's not profit that gets taxed, it's just net revenue they get to keep for free, that they got off of the bodies of New Yorkers, that they got off of like profiteering around our healthcare. So the New York Health Act, is important in Amber's case as well, because just because a private, because for many Black birthing people in New York, an issue is that the hospitals available to them or in their neighborhood have been chronically underfunded. For other Black New Yorkers, the issue is the hospital has been getting enough money, but there is zero oversight or accountability to ensure that hospitals that do have more than enough resources actually invest it into improving patient care. So, as I said before, the private hospitals had $1 billion of profit in 2016. What did they do with that money? These are the same hospitals that didn't have enough staff when COVID came, didn't have enough masks, didn't have enough ventilators, didn't have enough gowns. And so what did they do with the money in 2016? Mostly put it into like advertising and CEO compensation, not into actually improving the care that their patients get there. Yes, the base level of care is higher than the public hospitals, but even then we're talking about like a 1-star versus a 3-star hospital, when nationwide, so sorry, I'm getting on a tangent, but like New York has the most dangerous hospitals of any system, of like any city in the United States, by a lot. Like nationwide, only 2% of hospitals have 1-star, and in New York City, 66% of hospitals have only 1-star for patient quality. So there is something like hugely qualitatively different about hospitals in New York City. And so even like our good hospitals only have 2 or 3 stars for patient care quality, that monitors things like staffing, like infection rates, like readmission. Are people able, do people who seek care there understand their treatment plan well enough when they go home to not be readmitted within a week? So folks can just check that they're muted. There's the 2 trees. Or did someone need to unmute themselves? Is one is oh, yeah. 1,000, one is 1,000. Sorry.
Hi. Yeah, I just wanted to raise a couple.
One closest house is 1,200.
One everyone, please check that you're muted. If you'd like to make me co-host, Katie, I can mute people if that happens.
I got it.
And then there's been a couple things raised in the chat.
Sure.
One was, I believe it was like, particularly, I recall having the same experience as well with slide 6 and 8, how small it was and hard to read. And so it was raised like an interest in seeing those slides afterwards. Hopefully, if you're able to send them, that would be helpful to folks. And then another individual wanted to ask a question about funding. I know this participant as well. And so I encouraged I encouraged her to ask it in the chat, but if it's a good time, maybe that question can be raised now and you can table it if it's something that should be addressed later.
Yeah.
Jessica, if you'd like to bring your question, you're welcome.
I just put a copy to a comment view of the slides in the chat. So anybody who wants to follow along, you can open up at home.
Awesome.
Awesome. Thank you so much. I just wanted to clarify something, because obviously all of the funding stuff is really complicated, but in trying to better understand the disparities in funding, it's my understanding also that the amount that the state healthcare programs or Medicaid programs reimburse private hospitals has tended to actually be greater than the amount that they reimburse the public hospitals and those Medicaid patients, even though the like for the comparable services. Is that off, or is there?
That is exactly true, and I had just left that slide out for brevity, but now that you bring it up, let's mention it because it is.
I'm glad I didn't. It's so complicated, so I'm glad that I didn't totally understand.
So yeah, the fact that public insurance pays less than private insurance is inequitable everywhere and is causing health disparities everywhere. But the reason why New York has health disparities that are like 2 or 3 times worse than almost anywhere else in the nation is because the Medicaid knows that its reimbursement scheme is inequitable. And so they've set aside a separate pool of money called the Disproportionate Share Hospital Fund that is supposed to go to hospitals that serve a disproportionate share of people who are on public insurance. But instead, in 49 other states, that's how they do it. Like in Massachusetts, in California, there's a law that says essentially you have to see at least 30% of your patients need to be on Medicaid. I made that number up, but it's something like that. At least X amount of percent need to be on Medicaid, and then any percentage above that will take into consideration in how much you get from this funding pool. In New York, what they did was take the money we get from Washington and put it into 2 separate pools, one for the public hospitals to divide into and another for the private hospitals to divide into. And the money they put in the pool for the private hospitals is almost 8 times as much as the money they put in the pool for the public hospitals. And if you're like, Katie, that doesn't really make sense because isn't it the public hospitals that see more patients who are on public insurance? Yes, it doesn't make sense. The public hospitals do see more people who are on public insurance. And actually, the reason why is because many of the private hospitals illegally practice insurance segregation and discrimination. And so if you call one of the private hospitals and you have Medicaid and say this is my health insurance, I'm looking for a doctor for XYZ reason, they'll say, oh, I'm sorry, none of our doctors right now are accepting that insurance. Or all of our doctors who accept that insurance right now have a full roster, which is another way of saying we won't provide care to you. And you'll call, they did like a sting operation essentially where they repeatedly did this to demonstrate that there was a pattern where 2 minutes later somebody would call with the same medical condition but a different health insurance, and the private hospital would be like, oh yes, we can schedule you to see you next week. So the private hospitals are actively segregating their populations to only see folks who have a better paying insurance. And then they have used government corruption to essentially steal federal funding that is intended for the public hospitals to instead line their pockets. So this graph shows the 2016, I think, distribution of the DSH funding, and the blue bars show the how much money the hospitals are spending on un- and underinsured care, and the orange dots show how much money the hospitals are getting back from the government. And so what you can see is that the public hospitals are racking up tens of millions of dollars of debt every year, just providing care to people who walk through their doors, while the private hospitals are getting millions of dollars more than what they spent in the first place to provide care for a much smaller number of people on those insurances. So this is why I talk about the phenomenon in Brooklyn is kind of the opposite of what we see in the Bronx, where what we see in Brooklyn is kind of what I would expect to see given our funding structure, which is that the public hospitals that have been most deprived of public funding now have the worst maternal health outcomes. Whereas in the Bronx, Montefiore is one of those 5 private hospitals that has been getting like paid 8 times as much per Medicaid patient to see those patients. So Montefiore sees the fewest percentage wise of Medicaid patients of any hospital with maternity services in the Bronx, and they get paid the most to see that small percentage wise number of Medicaid patients. So there's really no excuse for them to not be providing excellent care. And I guess, and that's how we get to the next point of why the New York Health Act is important, is because it is as long as there is a profit motive in healthcare, as long as there are people who make money by limiting the amount, as long as there are people who profit by denying healthcare to people, as long as there are people who profit by having who can pocket the salary of the nurses that we should be hired to work on the floor, there's going to be people who will cut corners to make money and not reinvest the money that is given to them for the intended purpose of improving the care that is provided to them. So like just the profit motive in healthcare is deadly. And we don't know exactly what was happening behind closed doors at Montefiore, but we know they've gotten paid much more than other hospitals with better outcomes, and that and many elements of Amber's story and the medical neglect that she experienced to me sound like what happened when there's understaffing. So one of the main points of neglect in Amber's story is that her lab values had started to decline in December, and they weren't detected, and nobody saw that they were abnormal until Amber and her partner went to seek care from a separate provider, from a home birth midwife. And it was when the home birth midwife was doing a chart review and looking through the lab work they had brought with them that she was like, holy yikes, this lab value's been dropping for months now. We need to go and get you evaluated. And in my experience, when lab values get missed, it's just because you're so busy. When I come in, one of the first things I do as a floor nurse on a shift when I come in, if everything's going okay, if everything is safe, is I sit down at the computer and I look up all of my patients' labs for the past couple of days. If there's anything unusual, I go back to see the past couple of weeks, the past couple of months. I look at all of the trends, and then if there's anything wonky, I bring it up to the physician who's helping take care of that patient, and we have a conversation about what's going on with those lab values. Now, if I come on to a shift where I have 2 or 3 times the safe amount of patients assigned to me, I never get that 10 to 15 minutes to sit down at the computer and review chart values. And if shift after shift after shift, the nurses are going from one emergency to another, we never have a chance to sit down and look through our patients' labs and to think, and to be thoughtful about the numbers that we see and what it could mean for that patient's real, lived experience and what we need to be doing to intervene. So I don't want to universalize my experience, my experience is working as a nurse give me insight to my experiences working as a nurse. But, I think it is, uh, in my 10 years working, every time I missed a lab value, it was when I had more patients assigned to me than was safe. And almost every time that was the case, it was because the hospital had failed to plan, had either knowingly gone into a situation where we had too few staff, or failed to plan adequately for a very predictable fluctuation in patient census and acuity. And so we didn't have the resources to, get more staff when we predictably had more patients come through. And so the New York Health Act and single payer health insurance is incredibly important because it's really the first step in leaving for-profit healthcare. It's the first step away from privatized. The of all of the private entities within the health sphere, there's none more pernicious than health insurance companies, because the only way they make money is if they deny care to people, and is if more people pay into the system than they pay out to provide care. And so by getting rid of the privatized health insurance and replacing it with a single payer system, we take our first step out of generally a for-profit healthcare system, and we introduce a ton more accountability measures for our health institutions, because it's you don't have enough nurses. Well, we know exactly how much you get paid because all of your patients are on the same health insurance. We pay you, 100% of your income comes from the New York Health Plan. If you're not providing good care to your patients, we will have a lot more tools to intervene and to ensure quality care across all hospitals, because we've equalized income across all hospitals and unified the system that oversees, unified the entity that has the most say in how an institution behaves, which is the people who are paying the bills. So yeah, and I have this other note here that just it's not normal for us as a society to think that your access to healthcare should depend on what kind of job that you have. Having the primary form of that people access health insurance is through their employment means you need to be healthy enough to participate in those certain certain employment fields that offer insurance just to get access to health care. It's not normal for us as a society to have essentially agreed that poor people deserve worse health care. And so when I tend to focus a lot on structural racism when I talk about the racism and not race creating racial health disparities. But I'll venture into talking about interpersonal racism for a minute to say, babies aren't born racist. And so if a healthcare provider is racist or has internalized racial beliefs, they learned that from somewhere. And if you look at New York City right now and ask yourself a question, these doctors seem really racist. Where did they learn? Where did they get the idea that some patients' lives are worth more than other patients' lives? Well, we literally have our known currently society approved system of providing healthcare literally puts a higher dollar value on some patients' lives than others. And so even if it's very easy for that basic hierarchy of human life that exists in how we pay for healthcare to permeate how you think about how you treat and how you interact with your patients. And it's also super easy for once you get used to, well, it's okay to provide worse care to some people, it's easy for who those people you can provide worse care for and how bad that care can get to really go south. So Montefiore had a lot of money, but more doctors in New York City are trained at SUNY Downstate than any other hospital, than any other medical school. And that's the hospital where I was working as a nurse. And it is one of the most dangerous hospitals in America. So think about that. More doctors more doctors in New York City than any other medical school are getting trained at the most dangerous hospital. So many of these practitioners don't even have the necessary skills to save lives because they were trained in a place that was so dangerous they couldn't/didn't learn it. And so even if once they leave downstate and go on to better, more, fancier hospitals with more resources, we as a state, because it is a state-run university, have taught these providers that some people's lives aren't worth as much as others, and that attitude they carry into them with their career and can get mapped on whatever patient sits in front of them if the circumstances are difficult enough and if the alternatives aren't clear. So if we want to address interpersonal racism in healthcare professionals, then as a society, we need to stop imposing on them inherently racist payment structure that if you didn't already have racist beliefs, literally teaches you that some people are worth more than others. So it's I think that's I realized I put most of those points on a slide that I didn't get to. Yeah, so it's first step out of the profit mode of healthcare. It ends the system of medical apartheid and the unequal funding to hospitals. It provides automatic, comprehensive preconception, prenatal, postpartum coverage to every person in New York. And if we don't like the coverage that the New York Health Plan provides, there is a unified way to lobby and improve it, where our current fractured and divided system really leaves us with very few options to move towards systemic change. And then it seems dumb to say it as a bonus, but also it covers 1 million New Yorkers who don't currently have health insurance. So not only does it fix all of these other problems, but just this most obvious thing, 1 million people need health insurance. We've just been through a pandemic. Let's give it to them. So the how to pass it, we'll talk in a second because it's the same as this next bill. And the next piece of legislation I wanted to talk about is safe staffing law. And so I don't think there's a catchy name for it, but the current bill numbers in the Assembly is A108B, and in the Senate is S1168A. And this bill establishes minimum safe staffing ratios at hospitals across New York. And then it also establishes staffing committees within hospitals that are largely that are over half of the composition of those committees will be bedside nurses. And those committees will have the power to make ratios that are better than what the statewide averages are. And so the reason to pass safe staffing laws are just there's really no reason to not pass safe staffing laws, and that is reflected in the fact that I've never seen a bill with more in the state level bill in New York with more co-sponsors than this bill. So there's 150 Assembly people in New York, and I think 120 of them are co-sponsors on this bill. So it saves money in the long run because it improves patient outcomes. There's a pre-COVID study that showed that if we had safe staffing ratios in New York, it would have prevented 5,000 deaths. You know, I cried when I read that because, like, that's 5,000 people that would still be alive if hospitals just did, like, the very basic minimum of hiring as many nurses as should be working on the floor at any period of time. And then, like, thinking of the ripple violence, um, the rippling violence effect of, like, the effects that had on those 5,000 families and the effects that it had on the health staff that were working there and incredibly stressed when they saw these patients decompensating, knowing that they would probably be doing better with better care. And then knowing that this tweet I was looking at was from 2019. If 5,000 people died in 2 years before COVID, I like a frighteningly high percentage of the 50,000 New Yorkers who died may have been because there just weren't nurses enough to, like, monitor the ventilators that they were on. Like you can't, like, this isn't, like, you know, being an ICU nurse, you know, if a patient has a breathing tube, you have 2 minutes from the time there's a clog in that breathing tube to the time that patient dies. And if you don't see it in the first 10 to 15 seconds and are at that bedside for the full 2 minutes actually doing the things to unclog it, that person just dies. Like, I've seen that happen in the NICU, and I know that happened during COVID because my friends were telling me that. And because if you have one nurse assigned to 5 ICU patients who all have breathing tubes, someone's anyway. Safe staffing, like, there's no reason to not pass safe staffing bills except for that hospital lobbyists must be putting an extreme amount of pressure on leaders within New York State politics not to do it, because A, it would cost them a lot of money to actually meet safe staffing standards, and B, it would give both nurses and patients a legal avenue to seek redress if harm fell to them on an understaffed shift. So we don't know exactly what happened at Montefiore, and talking about accountability and transparency is something for folks who can stay for another hour we'll get into. But it seems very likely to me, listening to Bruce and Amber's story, that if more people had been working at Montefiore, it would be much less likely that all of the lapses in care that occurred. It seems, you know, hopefully I'm not speaking out of turn or projecting, but, you know, my experience as a healthcare provider and observing my coworkers, most people working in under-resourced settings in New York City really are doing the best they can by their patients, and the degree to which they have harmful beliefs about their patients is a trauma response and a coping mechanism to the extreme violence we've experienced during our training. And so I think so the cool thing about both the New York Health Act and the safe staffing laws is that they have the support to pass. So the only thing we need to do to get them to be laws in New York and to get them immediately improving the lives of everyday New Yorkers, immediately improving the quality of care at the hospitals where most people give, 98. I'm a huge fan of out-of-hospital birth. I'm going to do everything possible to make out-of-hospital birth more of an option in reality in New York. But at the end of the day, currently, most people give birth in hospitals. And in the future, people who hopefully not as many people will develop severe complications if they're receiving comprehensive person-centered care throughout their pregnancy. But if and when people do develop complications like HELP, which is the complication that Amber died of, if you have HELP, you do need to be cared for in a hospital, and we need those hospitals to have the staff on hand to handle those emergencies, to detect them early and to handle them properly. And by passing safe staffing with the New York Health Act, like, if we pass those two laws together, then we essentially we pass a law promising to pay for the staffing we're now requiring hospitals to have. Perfect combination. If we pass the staffing without the New York Health Act, we'll really put public hospitals in a position where they won't be able to meet the laws because they just don't have the money to meet the ratios. If we pass the New York Health Act without safe staffing, God forbid we normalize, like we just make the across the board payments too low and the across the board payments for staffing levels that aren't safe for any New Yorker. We pass them together. We've made a huge step towards improving health access for birthing people in New York. So for how do we get things passed in once they have the support? Once we have so there's 63 state senators in New York. So if any bill gets more than 32 co-sponsors, we know it will pass when it gets called for a vote. There's 150 assembly people. If we have 76 co-sponsors or more, it will pass. Both of these bills, as I said before, have enough co-sponsorship. So that just means that the Speaker of the State Senate and Assembly need to call it for a vote. I want to show you, so the Speaker of the State Assembly is Carl Heastie, who represents a district in the Bronx. And I just want to show you where that district is. So if you live here, you are super important in New York State because everyone is represented by an assembly person, but only people who live in this district are represented by the assembly person who can call things to a vote. And so if he is hearing directly from his constituents that it is important to pass any particular piece of legislation, that weighs heavily with the speakers because while his coworkers can be mad at him for not calling something to a vote, his constituents can vote him out if they decide that he's not properly representing them. So if you or someone you know lives in this district, please take the time to chat with them and explain why it's important to be getting in touch between now and June 10th. So New York State has a part-time legislature, which means that we only vote on bills from January to June, and June 10th is the last day of the legislative session this year. So as I said before, the New York Health Act has a 2-year implementation phase. So if we are able to get it passed in the next 2 months, by 2023, every New Yorker has health insurance. Every New Yorker has health insurance, and then the structure through which we can make structural changes in healthcare is much more equitable and straightforward. And so the map I have pulled up right here, this is the Speaker of the Senate is Speaker Stuart Cousins, who represents Yonkers. So I see one Stuart Cousins constituent in here, and I'll want to chat with you soon and later about a plan to get in touch with her. But again, if you know folks in Yonkers, if you know folks in this area, it would be very strategic to get in touch with them and loop them into what we've been talking about today. The other thing, here's the text of a tweet that you can use to tweet at them. Every time you at a politician on Twitter like this, they or their staff get a notification, and that's been a very effective way that the movement has used to get in touch with our local representatives. Once I for 3 months was calling a state rep asking for meetings, and then one day I tweeted at him why I've been asking for so long to meet with you, when will you meet with me? And it got retweeted by a bunch of my friends, and the next day someone from his office called me and said, hello, we heard you'd like to speak with the senator, are you free next Tuesday? And I was like, oh, tweeting to your politicians, they see them, they care, they work. So this is another great tool to have. And if you see us hosting Twitter rallies, even if Twitter's not your thing, even if the only time you spend on Twitter is during a Twitter rally, we use strategies that make that still strategic. So come on through. And if you have Twitter, please feel free / go ahead and copy paste this from the chat and go ahead and ping Carl Hasty and Stuart Cousins now to say that these issues are important to us. Also, if you want to like make it, if you are Twitter comfortable and want to do like a little thread and like, I'm here with Katie and the Save a Rose Foundation learning about things today, that would be cool too. We always love promo and helping get the Save a Rose more traction on Twitter. So, and then so a lot of the push right now is getting the speakers to call it for a vote. And the other way, besides calling the speakers themselves and saying, hi, please call this for a vote, the other way we do that is by calling our own legislatures, our own state assembly members and state senators, and ask them if they are a co-sponsor, to thank them for being so, and to ask them to prioritize the New York Health Act this legislative session, and ask them to ask the speaker to call it for a vote. And same thing with your state senator. So, and then if they, ask the people who are co-sponsors to prioritize it for a vote. And like, next PowerPoint presentation, I'll have some photos, but like if you follow politicians on Instagram or Twitter, you'll see they take selfies of themselves, and in the back there's like a bunch in the chamber of the state capitol, in the back you'll see a bunch of politicians just chit-chatting with each other. And that's because even if you're out in Buffalo and we're down in Brooklyn, both of our representatives are in Albany for a certain chunk of the year in the same room, working on legislative issues. And so by asking our legislators to initiate conversations with the leadership, the Central Campaign for New York Health thinks that will be a winning strategy, because Hasty has essentially said, like, I'll call it for a vote when assembly members tell me that it's a priority for me to call it for a vote. Okay, well, so we'll call our assembly members and tell them that it's a priority for us, and ask them to communicate that message along. But these two bills, I wanted to spend the first hour of our time talking about these two bills because they're the things we could get passed now. And the things that we could from June onwards have made a huge change in how healthcare is delivered in New York, and a huge improvement in the safety of care that is available to birthing people in New York. And then I'm going to open us up for questions, comments, and things before I spend time talking about anything else. But I do want to say I just put the form for the Save a Rose grassroots policy team, and essentially I guess I normally describe myself as an organizer within the Movement to Birth Liberation. The Movement to Birth Liberation is a non-hierarchical network of reproductive justice activists that are mostly connected through a database. And so essentially what happens is when people fill out the Movement to Birth Liberation form, or the form of one of our partner organizations like Save a Rose, is I see your street address here and I look up all of your representatives and put you in a database, and then help connect you if there are other people from within our network who are actively working on reproductive justice issues, or if your legislators are not yet in support of legislation that would advance reproductive justice, we try and help connect you with other folks to pressure them and work towards those ends. And hopefully we get easy lines of communications to elected officials who are sympathetic to us and who want to work in solidarity with us. Hopefully, we will be able to persuade legislators who maybe are not naturally aligned to us, but can be persuaded to when they see how the policies that we bring before them stand to intentionally improve the lives of birthing people in their district. Something every legislator has in common is they represent a district where people are giving birth. And so us, coming in with that angle should hopefully move most legislators into supporting the policies we bring before them. And then eventually, if folks aren't willing to vote on legislation that benefits the life of birthing people, then they probably shouldn't be in office. So hopefully, our movement will be able to work in coalition with others who kind of change who represents us in government, to folks who can, imagine changes, imagine things we haven't done before to transform maternal health into, from where we are starting to where we need to go. And so I'm going to pause here for questions, comments, and I have like literally another hour of PowerPoint presentation, but for folks who need to head out soon, the best way to stay in touch with what we're doing is to fill that out. And if you're like, I did fill out the form and I haven't heard anything about stuff going on in my district, that may be because you're the person who's going to start doing things in your district. So if you filled it out and are wondering what to do next, ask me now, reach out to me. Let's get in touch or come to one of the working groups, even if it's not like the working group you think you'll end up in, just to get a sense of how we organize. And then hopefully it's a movement, not a moment, and we'll look forward to working together going forward. Oh, and for the 8th, so let me just pause here, and then in a couple minutes, before I talk about any more policy stuff, we can just talk if there's any questions about what's happening on the 8th. But let me stop the share and say hi to folks. So any questions, comments, thoughts, concerns? You said this thing and I didn't quite understand how it connects. So for May 8th, we're planning on meeting in the Bronx, same place, same time, noon, at the Williamsbridge Oval Park, and double check the Instagram post to make sure I didn't say the wrong place. I think we may need help with specific tasks for that. So if and when we do, keep your eyes out for an email. I think fortunately a lot of the prep work got done for today, and we'll just be able to use for May 8th. Probably the big exception, or the big cool thing that having the extra 2 weeks gives us an opportunity to do, is to invite more politicians and elected officials to come out. Essentially, we would love for every elected official in New York to come to the rally, mostly to learn from us. We're going to have time for folks to share their own experiences. Many of the speakers who are lined up are leaders within the reproductive justice movement in New York. And so regardless of where your personal representative falls on the political spectrum, I think you can make a very compelling argument of the people who, the birth worker activists are hosting this rally, the people who are working to improve the lives of birthing people are hosting this rally, come out and learn from us and show support. And so we would love to have a good turnout. And so So a good step and something we'd love for people to do is to call their city council person, their state assembly person, and their state senator. Let them know there's been a change in time and place, and essentially ask if they or someone from their office would be able to come out. And then as far as like of politicians who come out, who would we give a platform to, or who would we want to speak? Essentially, like if your politician indicates that they're coming, get in touch with me, and then we can like essentially float it through the Save Rose team and see if we're all in agreement that that's somebody that we would be comfortable sharing our platform for or platform with. But I keep hosting working groups and not a lot of people come in. When they do, they're like driving or like not on their computer, and I was always hoping to get them to help me do database entry work. Anyway, keep your eyes open for a working group where if you have time to just help me with database entry, to do that. Because I want to work on making a legislative tracker. So essentially taking all of the legislation that the movement and the Save Rose team care about, and then putting, be able to see very quickly each legislature if they're a co-sponsor of all of those things, and essentially like the metric I'll be suggesting to the Save Rose team we use is like, if they support all the legislation we do, awesome, let's share our platform with them and have them speak to the importance of that legislation. And if they don't, let's have them come to learn about why we think these particular things are important. So I know I see a lot of people in this Zoom who do know their legislators, who maybe have met with them in the past couple of years organizing with the movement. So this is one of the things we were talking about, of like why it's good to build relationships within the office, to know the names of people who work in the office and know who does what within your legislator's office. Because those are the folks to call now and say, hi, you met with us last year. It was amazing. Thank you so much. We're having this rally. We'd love to have you come. What do we do next? I honestly realized, like, even with legislators who I have good relationships with, I didn't know exactly the best and quickest way to like see if they are available, and like to match availability with interest with the specific policy points that we wanted to point out. So that's one of the things that we're learning together, this process, putting this action together. And so for folks who that seems like a good next step, please, or in developing a relationship with your offices, that would be amazing. Let me know how it goes, and we'll work together to come up with advice for future actions of like how you can invite your politician to come and be a part of the movement and what we're doing. And then I think I think a lot of people got the memo that we were rain checked and there was not a big showing for the poster making party, but I'll probably also do another poster making party on if the 7th is my partner's birthday, sometime beforehand. So we can just say hi to people and get ideas while we make our signs. So that, I think, is the practical announcements that I had. So how are you guys all doing? Do you want like another hour of reparations and policy stuff?
I think it'll be nice to pause here to just welcome anyone's input, responses, other questions. Again, maybe questions that might not be answered right in this moment, but just to check in and have a breather, and then leave a little room for people to slip off if they need to slip off. And then, hop back in, Katie, because it sounds like you're willing and interested to provide more information. So now, with some version of this breather, it will be nice to hear from anyone who's present about what you are inspired about, what you are excited to engage in or with in this whole year, and any pressing things that you just want to speak or share on, and then we can maybe slip back in around, I don't know, 120-ish if it doesn't organically take longer than that. I'll start by saying I am inspired by all of us present. I am continuously inspired by the simple actions that people are taking on the ground. I'm inspired by Katie and the movement to birth liberation, and just participating in some of those calls and seeing the effects of working in pods and in groups and in coalition, and seeing also the effects of, you know, the simple things we want to get done, like seeing them move forward and just having the proof of that. It's been inspiring, and it definitely feels encouraging to continue participating. And of course, inspired by Amber Rose Isaacs. Even though I didn't know her personally, there were at least 3 to 5 of my individual peers who did, as birth workers, or, you know, Bruce, of course. And so just knowing what she was about and who she was and how she's continued to live on in this way is very inspiring as well. So thank you, Amber Rose Isaacs, for your role in all of our work as we continue to press forward.
I want to echo everything that Mila just said. Thank you. You perfectly articulated much of what I was feeling, and I just feel very grateful to have found this community, and it's, yeah, there's so much power here. I was curious. I know that there's a big legislative agenda underway that requires a lot of work and attention, but it's also, as you know, the primaries in the city coming up, and we're like gonna have an entirely new council almost, and mayor, and so I know Katie, that you had that Instagram live with Lindsay Boylan, and I'm curious if there's any effort to, like, maybe even in coalition with other organizations, to somehow like hold some of the mayoral candidates accountable, in particular. I don't know, any local officials who could potentially have some big impact in like the RJ birth equity space if they come to power. Because I've seen a few council members put out like their own sort of platforms around this, but it hasn't been something that I've seen come up in any of the conversations. So I'm curious if that's like an avenue that might be worth exploring.
Yeah, well, but before I answer that question, I think we have city council candidates in the Zoom if they want to unmute themselves and say hi, and because that's one thing that has made me optimistic about the coming city primaries is how many candidates have been coming to movement stuff to learn. So if you're a city council candidate and want to say hi, feel free to unmute yourself. Maybe I don't. Maybe she's anyway. Maybe she stepped away. But so I think coming up, when city council's candidates started to get in touch with me in December, I think my thought process, like essentially my personal thought process, was this is super important and something that I hope as a movement we're better able to handle in 2 to 3 years from now. Mostly because I'm a learn as I go activist, and because I was working at a state-run hospital, so much of my energy and attention has just been on state level interventions that I don't know if I have like a nuanced enough policy platform at the city level to to really like distinguish between, most candidates, thank God, are pro mother. Most candidates, thank God, are pro birthing people and like pro reproductive health. And so I think the rub will be okay. So when it comes to spending money or upsetting current power structures that we have to be able to improve the lives of birthing people, are you willing to do that? And I'm not aware of um, I didn't have, and I'm not aware of others that had those types of kind of litmus test policies specific to reproductive justice. So I think for me, what's been important um, in shaping my, at least for this election cycle, the advice I may have to offer to other folks within the network is that, the medical industrial complex is very similar in its origins and in how it is currently run to the prison industrial complex. And so while we currently don't have as a developed uh, policy agenda for the abolition of the medical industrial complex, thank God prison abolitionists do have a much more developed agenda. And so I've been kind of using people's stance towards the policing and the prison industrial complex as a stand-in for me of like, okay, well, when we do develop a policy that starts midwifery schools, that opens a new midwifery school with every CUNY school and makes midwifery education free, and a way that we have to do that is maybe by spending less to train OBGYNs, which could be a prickly issue with the doctors. So we're like, we don't have that ready yet to say like, yes, no, would you support that? But we do have yes, no, will you defund the NYPD to instead invest it in communities? And I think that that's a helpful proxy for us to have the types of candidates that will work with us when we do get to the point of having a more developed city level plan to address RJ issues. Um, and then I guess I'll also say like healthcare is a human right. And in New York State, that is not just a platitude or like a hashtag to say, that is a viable policy that could pass in the next 46 days. So for, for me, like I wouldn't support a candidate in the state of New York that doesn't openly talk about and support the New York Health Act. And currently, there's only one mayoral candidate that does openly support the New York Health Act, and that's Dianne Morales. So she's got my vote. So as a non-hierarchical network, we don't really do endorsements because there's no like central authority to make decisions on like who is or is not, but there is a consensus amongst core organizers that healthcare is a human right and we should pass the New York Health Act. So I think it's fair to share if you're not paying super close attention to Twitter, you may have missed that Dianne Morales is the only pro New York Health Act candidate. So I'm sharing that. Can Mayoral candidates don't have much to do with the implementation of the New York Health Act. So there's really no reason for them to oppose it because, there's like, it won't come back negatively on them. It only shows that they don't support universal healthcare or healthcare as a human right if you don't support it. The thank you for that question. What else are you guys thinking about?
Well, those of you who have said you can't stay to the end, obviously, thank you for being here, and feel free to slip off as you need, as it works for you. We're really happy that you've been here with us all this time. And Katie, I don't know if you're still inspired and if the folks who are still on have an interest in still listening on. If you're still inspired, I think it would be great to go ahead and offer more of the legislative details of what we're aiming for.
Awesome. Yeah, so um let's do that. So I brought up safe staffing in the New York Health Act because those could pass this legislative session that ends June 10th. But then there are two other big things, main things I want to share with you guys, and those are both around the theme, both on reparations. And so this is essentially our 2021 plan, New York Health Act Safe Staffing. Our 2022 plan will hopefully be a state level bill that initiates a process of reparations for New York State's participation in slavery and segregation. And so, and that's because in 2023 or 2022, 2023, we also hope to be able to pass some version of Amber's bill or a piece of legislation that Bruce and I have been working on for the past several months, and hopefully will have ready and have received more stakeholder input to have it a place to bring to legislators in by next fall to make into a bill for the winter. So I'll pause here to say that, like, if you're familiar with the, like, I'm a Bill sitting on Capitol Hill, the cartoon of like how bills get passed and they go from one house to another, then that is a helpful and true description of how bills get passed both at the federal and state level. But something they left out of the cartoon is, like, the cartoon starts with "I'm a bill on Capitol Hill." Who wrote that bill? And how did it get on top of Capitol Hill to begin with? And that is a process that was very, I think, is very not untransparent to the general public of how legislation actually gets written. And when I first started going to the offices of legislators to share about how dangerous conditions were in the hospital, they essentially, they would listen to me and they were appropriately concerned. And then they often asked me a question like, do you have any legislation I could sign on to that would fix this issue? And I'm like, what do you mean, do I have any legislation? Like, aren't you the legislator and I'm the nurse, and I should just tell you what's happening in the hospital and then you come up with the law to fix it? And the answer is yes, that should happen that way, but no, currently state government is not resourced or set up in a way to really allow individual legislators to research deeply, understand thoroughly issues affecting their constituents, and translate that into novel legislation. So typically what we see happen is either legislators they come in with a particular expertise. They used to be a teacher, they used to be a lawyer, they used to be an environmental, whoever. And so they do write great novel legislation about the thing that they have their expertise in. And anything that's essentially not their expertise is either handed to them by an advocacy group or a lobbying group that has an interest in addressing whatever issue through legislation. Or you have sometimes legislators that will try and, like, borrow legislation from other states, or kind of try and retrofit legislation that work for one group of people to try and address an issue with another group of people. So one example of this is that in 2019, the doula bill came out, or a state level doula bill came out in New York, and it was super problematic because the legislator who wrote it essentially like heard there was an issue with maternal health, wanted to write a bill that would benefit birthing people, heard doulas were good for birthing people, thought, well, let's put that all into a piece of legislation for doulas. And so she took a piece of legislation that had been used 20 years ago for midwives, essentially crossed out all the places it said midwives and put the word doula, and then said, like, here's a doula bill for doulas. And it's like, well, that didn't really, didn't address, she spent an afternoon on Google to familiarize herself with the issue. It didn't really address the needs in the community, and it didn't work for doulas because it was a bill for midwives that she had just tried to retrofit. But the kind of the flip side to that is, like, I do think that that legislator was, it is at least partially well intentioned, in that they, the time it would take to develop relationships with stakeholders within the community to familiarize yourself with those needs and then translate it into research is just far beyond what any state legislator has the resources to do with 2 or 3 office staff managing an Albany office and a district office and handling all of the other concerns that that affect them as legislators. So in the I guess, so that's a long way to say I had this experience of legislators asking me, do you have a bill to fix that? And me being like, no. But it got me thinking about, okay, well, if it really seems like there is nobody else out here writing those types of bills, and, going to many maternal health organizations and asking them, are you working on this? Can you work on this? Will you work on this? And essentially the across the board answer being that organizations did not have the resources to focus on state level policy. I started thinking about, okay, well, how does one write state level policy, and have been reading and learning along those lines for a while. And then tragically, after Amber died, Bruce was put in a very similar position where he was meeting with politicians who were asking him, who had just lost his partner and was grieving, and like most expecting fathers, was not a health policy expert himself. Bruce, do you have any bills that would address maternal health? And him being like, no, not in the past couple of weeks. I have not totally have a comprehensive knowledge of the potential legislation pending out there and which ones could or couldn't help. And so fortunately, when Bruce and I linked up, it was at a point where I'd already been thinking about this for a while, and more ready to start putting what I've been learning about writing policy into actual Word documents. And like, the answer to how does a bill get onto Capitol Hill is, first you put it into a Word document, you get a bunch of other people, you get a bunch of people, hopefully, that will be affected by that bill to participate in roundtables and to participate in Zoom discussions, to go over the language of the bill, to talk about what the intent is, and to, really hammer, really decide with the stakeholders what we want. And then bring it to, and then we bring that Word document to legislators and say, like, hey, this is an idea of a bill we have. Can you help us make this into a law? And so from that point, legislators do have the resources. There's there's a pool of lawyers in Albany that, like, once you have a bill to more or less what you like, the main points figured out, they can read it through and like make sure it doesn't break the state constitution and put it into legalese. And so the bill that Bruce and I are currently working on is really just to address kind of the most pressing issue in Bruce's life and in many lives of those who have lost people to preventable pregnancy related causes, which is just that there is no official, formal, legal, there's organized response to a preventable parental loss. Um, there's, it doesn't trigger any social services. It doesn't, uh, you know, no one shows up the next day and helps you take care of things and helps you walk through this process of having just lost the often your life partner and the person you are planning on being with for a long time, and the person who's going to co-raise the child that you are anticipating, and so hopefully expecting and waiting for, and there's no financial support to replace the lost income of the parent who died and is now no longer working, and now the new need for childcare, whereas you used to have two parents, so maybe one could work, one could stay home, and now you either are home with your kid or you're out working and have to arrange some other childcare, and there's no support for you. Um, there's no formalized support for those families beyond what the community comes together to do. And while the community response is often beautiful, and this Zoom is in part the community response, we know that that is not a, a like an equitable. That's not a equitable system we want to go forward with, because GoFundMe's only work if people in your network have money to give to them, and we've seen maternal deaths that the GoFundMe's barely raise any significant amount of money for families that now have significant financial burdens in the wake of having lost someone to pregnancy. And the particular, the insult to injury when we're talking about pregnancy related deaths is that we know that most of them are preventable. So we have data that show that 60% of maternal deaths nationwide are preventable. And and as I was speaking about before, New York has the most dangerous hospitals of any state in the nation. We are ranked 50th out of 50 for hospital safety in the country. And so far nationwide, 60% of maternal deaths are preventable. I think it is very realistic to say that in New York, an even higher percentage of deaths are preventable. And that means most deaths are preventable, more likely or not, when there's been a pregnancy related death. Even before we hear any other details, we can make a fair assumption the odds are with us that something could have been done to keep this from happening. And so the only avenue of recourse families have after the death of a loved one is by filing a malpractice lawsuit, and that's super problematic for a lot of reasons, if not just the most basic, that if we know that most deaths are preventable, why are we placing the burden of responsibility on a grieving family to prove that it was and try and improve the medical system? If we know most of them are preventable, the onus should be on the medical institution to be forthright with what happened that they could be doing better in the future. But malpractice laws disincentivize hospitals from, they place the burden on the family, and they disincentivize hospitals from sharing what they may have been able to, what they may be able to do differently in the future to prevent something from happening. Because if you admit that you could do something differently in the future, then you're opening yourself up to liability in the case that just had happened. So even if malpractice did work it would be problematic because of places around the family. And also, it's a 2, 3, 4, 5 year long process. And if you just lost a parent, like the most expensive time, the time you need the money the most if you've just lost a parent is in those first couple of months to years, when the need for childcare is the highest, when the surviving parent's ability to work may be compromised because of grief or because of childcare responsibilities. So, the time when the family needs the money the most, they aren't getting it because the only way they may be able to get a payment is through a multi-year long process after the kids in school and the financial demands may have lessened. So even if it didn't work, it's not a good idea. Also, it's not working. So a very small portion of people who experience a negative outcome or abuse in the healthcare system are even able to find a lawyer uh, who's willing to file a case and sue. And so and of that small percentage of people who are able to find a lawyer willing to take their case, only 22% of them end up with a payment. So it's like, most people uh who are experiencing some kind of violence within the healthcare system never never see any kind of justice or accountability through the one through the one avenue that we've established for them to have accountability. Now also take a look at this. 90% of physicians have been sued in high risk specialties, are sued during the course of their career. So what's going on there? So I mean, either essentially all doctors are bad and we don't have a system to improve them and make them better, or the system is so messed up that there's no alternative besides suing your physician if you end up in a place where your ability to work has been compromised. But this should be very concerning to us if that 90% of OBGYNs have been sued. Does that mean 90% have like done something egregious to their patients and have not faced any accountability besides maybe paying a fine? Or what's going on here? The system we have is not solving the problems that we are experiencing. And I guess, yeah, the last slide just says it shouldn't work, it doesn't work, and it won't work because the laws that determine who can sue what for what were written by white men who were actively participating in human trafficking and owning enslaved peoples. And the laws they wrote in America value property over people. Um, there's huge racial disparities in in malpractice payouts, because a part of how the payout is determined is by looking at how much money that person may have been able to make over their course lifespan. Well, because of racism and misogyny, black women make less money over their lifespan than white men on actuarial tables, and then that racism and misogyny perpetuate themselves into lower malpractice payouts because their lives are literally less valuable according to the metrics that the civil courts are using. And so what white the white men made the laws that we are using often to try and sue other white men when black women have been the victim, and it shouldn't be surprising to us that the system is rigged against ever really seeing justice. Um, and then, furthermore, it's based in a system of retributive justice, which is you do something wrong and we punish you. And then, and I think, as I've mentioned before, I think it's never that simple in healthcare. Either it puts us in a situation where you have a bad healthcare provider that, instead of not being able to practice anymore or being forced to improve whatever whatever about their care was bad, they just pay a fine and move on. Or you have good providers who are in bad situations and they get sued and emotionally destroyed, and the bad situation they were working with never gets addressed. And then I use quotes around good and bad providers because the health system in New York is so violent and so dangerous and so far gone that I don't think there are any clear distinctions of good and bad providers anymore. Like I won't share now because it's so it's so shameful for me to think about some of the things I did as a nurse that, like, I'm coming to terms with in therapy because of the extenuating circumstances that I was surrounded with, but it really normalizes things that should not be normal. The practice environments many of us are working in, and a malpractice suit doesn't give us any space to explore or change those extenuating circumstances. If Amber's values were missed because one or two nurses were running the prenatal clinic when there should have been 10, then then suing those two nurses because they missed a value isn't going to isn't going to make it any less likely for the next person receiving care at Montefiore to not fall through the cracks, to not have their lab values missed, and end up in an emergency that the staff can't handle appropriately, or doesn't, or has a hard time handling appropriately. And so essentially the bill that Bruce and I are working on has two parts and maybe a third, because at the last teach-ins people were asking me good questions that I didn't have answers to, and it made me think, oh, maybe there needs to be a third section to this bill. But essentially the first two sections of the bill, the first just establishes reparatory payments to families that have experienced preventable pregnancy loss, and kind of with the understanding that obviously no amount of money can replace the life or do justice to the life that was lost, but some amount of money can decrease the financial difficulties that loss will necessarily cause for the family. And so it establishes the number. I'm throwing out numbers that we've are hovering around. So I'll throw out the numbers, but I think the intent is more important. And if in our conversations with stakeholders we realize these numbers don't match the intent, we'll change the numbers. But the idea would be that essentially as soon as a death certificate is processed that shows that there was a pregnancy related death, that family would automatically receive a $50,000 payment within a couple of weeks to help with burial costs. And just like, so you can take, if you have to take time off work to take care of the baby, you can just kind of like, take the pause that you need to deal with your life in the immediate aftermath with that $50,000. And then some in like the first couple of months, and the specific details of how the payments work out will be things that we talk about and kind of figure out with the legislators who we hope to work with on this. Essentially an initial payment just to go to burial costs, and then a yearly payment from the time of the death until the time that the youngest child turns 22 years old, to now the secondary caretaker of whatever children were left behind, so that parent can be a full-time single parent without needing to work outside of the home, if that's their choice. So the numbers we're playing with is essentially like $100,000 for a family with one child, and then an additional $10,000 if there are other children left behind. So if tragically, Decheka Floorman is one of the women who died at SUNY Downstate when I was working there, and she left behind 6 children. So that family would be getting $150,000 a year until the kids start graduating. And then at 22 years of age, the children would come into a trust fund that is intended to make up for the support they would have been able to receive from their parent throughout adulthood. The emotional, financial, physical support throughout adulthood, and replace an inheritance that they may have that they otherwise would have received. So those are the payments that it sets up. And then the second part of the bill is to establish a pilot tribunal of truth and reconciliation. And so essentially acknowledging all of the limitations within a malpractice process. We want to essentially reinvent a process for both family and staff to be able to discuss frankly like events that transpired and what happened leading up to Amber's death. Why weren't the lab's values met? Am I right that there weren't enough nurses working and it fell through the cracks? Am I wrong that there were a ton of nurses working and something else was going, we need answers from Montefiore. If that's the case, they need to explain that to Bruce. They need to explain that to the family of what was going on, so that there's clarity, transparency, and not trying to hide or obscure things that contributed to Amber's death and that can be changed to make things safer for birthing people in the future. And then the last sentence in that section, to establish a pilot program, essentially says that the people who participate in that pilot program will compile a report with suggestions of ways to, I think big picture is we would completely replace malpractice processes with processes of truth, reconciliation, and reparations. And that if you experienced harm because there were overwhelmingly bad circumstances, then the society that allowed those bad circumstances to occur is agreed to take care of you through reparations, and the truth and reconciliation process brings to light connects those dots and brings to light what those circumstances were that led to the bad outcome. And if in the truth and reconciliation process it becomes clear that there are providers that actively harbor biases towards Black people, we get them out of healthcare, because they shouldn't they shouldn't just pay a fine and move on. If they actually are intentionally providing worse healthcare to Black people, they should not be providing healthcare anymore. And we need a process that is able to kind of suss out those two potential causes when we see racism happening in the hospitals, so that we can appropriately intervene and address them. So essentially, an optimistic timeline for this bill is that we are able to get input from multiple stakeholders and multiple families that would potentially qualify to receive payments under this bill in the next couple of months. And so we are able to bring it to legislators in the summer or fall to find a sponsor. And then we're able to do teach-ins and get folks to get their representatives to co-sponsor the bill. And then we try and get it passed. But that's an optimistic timeline, because it could very easily take us 2 years to, because all of the stakeholders are grieving families. It's not like I send them an email and I'm like, you haven't responded to the email I sent you yesterday. It's a very organic, when we're able to, when people are in the right place to talk about the bill, that's when we talk about the bill. So while we're working on coming together on the language, and kind of dreaming up this original legislation, like I don't think there's a similar a similar publicly financed reparatory payment program for medical harm anywhere. So we would be like trying something new in New York. And so the thing that folks can be working on as so I guess, well, before I zoom on, if you know stakeholders or if you are a stakeholder yourself, please reach out, let me know. I'm happy to send you a rough copy of the bill, and I'd love for you to be a part of this conversation, or if you know or within your circles are people who have lost our families that would qualify, please let them know that we're working on this and we'd love their input. And so but besides that, or if you don't have those types of connections, the bill that we can be working on to pass, that we should just be working on anyway, but particularly because it is but because like our bill won't pass if this bill can't, is a bill that initiates the process of reparations for New York State at a state level. And so this is a bill that is in the assembly right now. And what it would do, so it's in the assembly right now. I clicked on the link, so this is the summary of the bill. And right here, you can see who the co-sponsors are. So I just, off the top of my head, Mila, I know Taylor is a co-sponsor. And I know Lindsay and Sam Havesi is not a co-sponsor. Lisa, I know you're senator, but not your assembly person. My person, Zinnerman, is a co-sponsor here. But I think we have 38 co-sponsors on the bill, and as I said, we need 76 to pass anything because there are 150 assembly members. And so essentially the work we have to do, the work folks who are not actually contributing to the language of the bill have or can be working on and doing in solidarity, is working to get this bill passed. So what this bill does is it does not pay reparations, but it establishes a committee that, where is it? It doesn't pay reparations, but it establishes a committee that the end work product of that committee will be a recommendation of the actual physical form that reparations should take. So within the American community of descendants of enslaved peoples, there's a large diversity of thought of the form reparations should take. So is it like an individual payment to people who can prove that they are the descendants of enslaved people? Is it community investments in disproportionately Black communities, and kind of investments into scholarships and infrastructure and structural programs? Is it individual payments to anybody with any African ancestry because the racism that slavery created affects all Black people, and it's difficult to prove, it can be difficult to prove if you are a direct descendant from enslaved people because it was prohibited for many to learn to read and write. So that is just to say there is, I think, the consensus that the small number of families who have lost people to pregnancy related causes has kind of come together of like, okay, well, this could make sense as reparatory payments to having had lost someone to preventable pregnancy related causes. There is no such easy consensus of the form reparations should take. And so by the first step being passing a commission to study the issue is actually a great way to democratize the process of determining the form that reparations will take. And it's importantly, it's not just any committee. It will have 12 people on it, and 9 of the 12 people on the committee will be appointed by one of 3 Black-led organizations that have been a part of the Black liberation movement and a part of the movement towards reparations for 50 plus years. And so it will be, specifically folks with expertise in African American studies, who are on that commission, being, having state resources to help in the process of coming together around what the form that reparations should take. And so so essentially, in the meantime, the thing that we need, or like the 2 bills I talked about before, the New York Health Act and the safe staffing, like you should, and it is strategic. Later in a different Zoom, I'll explain like how it's strategic depending on where your person is, of how to reach out to them to get the New York Health Act passed. But this one does, but either of them have the support it needs to pass. So even if your person isn't in support, we could still get it through. This we can't pass yet. This we don't have the support to pass. So we need at least 35 other assembly members to sign on as co-sponsors. And so the way we do that is essentially, if you don't see your assembly member here, and if you have capacity, then my strong encouragement would be to start making calls to ask them to sign on to the reparations bill. And then essentially, if after a couple of weeks of asking them to sign on, you're refreshing this page and seeing, I'll send it. You're refreshing this page and seeing that they have not yet signed on, then to ask if you can have a sit down with them to fully explain more about the bill and why you think that we should pass it. And then obviously in at any point in that, get in touch with me and I'll try to help connect you to other folks in your assembly district to be working on that in tangent. If your person is a co-sponsor on the reparations bill, there's very little talk or buzz about the reparations bill right now. Like, there's not a lot of people talking about it on social media. And so a great, easy, strategic thing to do would just be to thank them publicly on social media. So either through Instagram or Twitter, being like, Assemblymember Taylor, thank you so much for your co-sponsorship on Assemblymember Barron's bill to initiate a process to start reparations in New York. We hope that more assembly members will sign on and we're able to pass this legislation soon. And that way, they get warm and fuzzies because you're thanking them as a constituent, and they get positive attention. Your person gets positive attention, and the bill gets and the idea of reparations gets introduced and normalized within conversations about New York State policies. And then same if your person's not, then let's work on, because I just sent you like a basic idea of a script that folks can use for asking about asking for folks to sign on to the reparations bill. And then obviously telling your friends who live in other districts and kind of looping them into the work that we're doing. Do you know who your assembly member is? Do you know if they're a co-sponsor on this bill? Oh, I can help you look that up. Oh, let's talk about how you would reach out to them, and growing the movement in that way. So that's the other hour that I had on reparations that I'm so glad you guys stuck around for. What are you guys thinking? What questions, comments? And Sandra, I don't want to put you on the spot, but I do know you're a Stewart-Cousins constituent. So if you had any specific questions about reaching out to Senator Stewart-Cousins, or what to say, or ways to organize in Yonkers, I'd be thrilled to to field those for you.
Yes, thank you for that, Katie. I'm just trying to figure out the best approach to, talking with her,
Mhm.
just because of the fact that I could be a very blunt person. And I just finished my classes now with for the semester in midwifery school. So I will take this 2 weeks to really hold in on this issue. And I'm coming back home as well on Monday. So I will be in contact with you this week coming up, because I want to take advantage of the fact that because I'm coming back home, this meeting is like me introducing myself to her is like part of my goal list while I'm around. So we will be in contact.
So looking forward to it. If you ever want to do an IG live uh of like being a person in the district, I would love to do that, if for no other reason to send to a couple of other Stuart Cousins constituents. I mean, like,
Yes, that sounds something up my alley. So we will be in contact.
perfect.
Yes.
And then I guess just off the top of my head, I think I am also a blunt person, and I recently had a little bit of a meltdown at my post office because it was very busy and I had to wait for a long time and I wasn't vaccinated yet and there were a lot of anyway. I called my congressperson and I was like, I will primary you myself if you don't fix our post office. And then I was like, oh shoot, I think I'm too involved in politics now to like leave angry, threatening constituent voicemails. Like, I may meet with this guy in the next year, and that's not the foot I wanted to put forward. Okay, right.
Right.
So I think the thing that helps me around that, particularly with my state representatives, is getting to know the people who work at the front office for my reps. Because even if I'm annoyed with my assembly member, I'm not annoyed with Tallulah, the very nice lady who answers her phones. And like often I get this sense that people's staffers probably have the same political values as the people who represent them without the same without the same entanglements or needing to keep a similar public face. And so I found it's very easy to have very easy to find a good rapport with people who work for the state senator. And so then it's always like, if you could remind her, like, and because I'm talking to someone who I feel comfortable with, I'm able to, it's much easier for me to like say the things I'm going to say in the nicest way possible because I'm talking to Tallulah and not to the member themselves. Um, so I think that's like most of the time when you call, you won't be speaking to the senator herself. And so essentially getting to know the people you're speaking to and what their political leanings are. Like I've had staff pull me aside and be like, listen, like my boss isn't paying enough attention to this issue. And I think if you do this, that, and the other thing, it will like kind of move them in that way because I've seen them be responsive to that before. So like forming those kinds of alliances and relationships will be super beneficial. And then like coming into the first meeting with your folks with just assume that like anything you want them to do they haven't done yet is just because they haven't heard it yet or heard your compelling argument yet. And then let frustration build from there. Does that make sense? Like starting off giving them
Yes, it does.
the doubt uh and then trying to move and then only when they've proven to you that they said something in a meeting and then didn't do it or are saying something to you in the meeting that is actually dumb, that's when you can be like, okay, well, let's break down the thing you just said there. I will say something to thank Stuart Cousins for is that she did fight pretty hard in the budget negotiations against any Medicaid cuts. and she did come out early to ask Governor Cuomo to resign. Um, in light of both the nursing home issue and the sexual assault and harassment allegations. And so when you call her, you can say thank you so much for her leadership on these issues. And now here's all the other things I'd like for her to be doing or calling for a vote.
I am writing notes down because obviously I'm so far fetched from her situation and I have my own thing going on. So
yeah, so that's to start, and then we'll meet up on Instagram and
right,
go over things again in a week or two.
Okay, thank you so much.
Yeah. Myra, Lindsay, any other things to say or chat about while we're here?
No, none for me. Thank you so much. This was so great, Katie. I'm so glad I hung out and listened to everything that you've been working on and everything you've been working on with Bruce too. It was nice to hear some of the details of what you have been talking about together. So thank you for sharing that.
Yeah, thank you guys so much for being here. And I'm just Mila and Sandra, Lindsay, Sam, and I have been scheming about their Queens representatives who are like neither here nor there on a lot of issues. Like they're not against anything, but they're not for anything either. And I think Sam and Lindsay may be the ones who get them to come out on some of these issues. And so thank you so much for being here. And I look forward to putting our heads together on how we get Havesi's co-sponsorship on this.
And yeah, very exciting. They're definitely going to get them like to name things out loud.
And then, Mila, I think your reps are like good and on everything. So I think like essentially whenever you have the capacity to have like a getting to know you type meeting with your reps, then let's do that. Because Jackson seems like really, really out on front on a lot of education issues. And my guess is like if we develop a relationship with him, he will easily lend his same type of support to birth stuff. We just have to say hi and let him know what to do and where to go.
Word. Okay, that's to come.
Exactly.
Yeah, I'm glad also
like pressing reason to talk to Senator Jackson yet, but like I think he'll be a good ally to have just to have a relationship with, because you and many other movement people are in the district. Well, guys, thank you so much for spending all this time with us. I look forward to seeing you Movement Monday on May 3rd, and then again next week, May 8th. Have a great afternoon.
You too. Bye.
Bye.